So briefly, we're just going to go over how does interventional radiology really fit into the care of neuroendocrine disease, and specifically lung carcinoid. I can tell you that the data, when you really do a PubMed search and you look at lung neuroendocrine disease and liver metastases, there aren't many papers that are specifically devoted to that. There's a lot of papers out there that have numerous subtypes grouped together. So we'll talk about that as we go. As you heard, I think that the multidisciplinary aspect of neuroendocrine care is the most critical for the patient. And you're already self-selected, and obviously it's a smart group of people that are looking for these therapies. And I agree with Eric. I think that there may be a chance to see most of these therapies at some point in the disease process. The question is, where do you play your card, in what order? So the diagnosis, the older diagnoses were really biopsy and angiography, and angiography really isn't used for diagnoses anymore unless there's some question of, is there a hypervascular tumor in the liver or the adrenal glands or the organ of Zuckerkandl. Interventional radiology, we see patients in clinic. I work very closely with Eric. I'm fortunate enough to be with him in clinic at Rocky Mountain Cancer Center. And it's invaluable to be able to sit down either with the patient, with both Dr. Liu and I, to discuss the options, or at least have him a couple doors away. You've probably heard about local ablative techniques, and we're just going to touch on those very briefly because those can be done surgically as well as percutaneously. There's catheter-based techniques, which is what I specialize in, and catheter-based techniques are usually infusing something into the tumor, whether that's a bland bead, something that contains chemotherapy, or radioembolics. And we'll talk a little bit about portal vein occlusion, where do we sequence this with PRRT, as well as a violated ampulla, which is somebody that's had a Whipple procedure or a stent within the biliary tree. These are the multidisciplinary team of people that are involved and how we fit into it. Next, please. Venous sampling. This is something that's come up a little bit more frequently with Eric being in town. And there can be tumors inside of the adrenal glands that can be difficult to visualize. If you can see them on MRI, cross-sectional imaging with CT, then it's pretty straightforward to address them. If it's hyperplasia of a gland that's increasing hormone output, that's a little bit harder to see, and we'll actually put the catheter into the adrenal veins of the right and left side and draw samples off looking for different hormones and proteins, and it can help us localize if something's more left-sided or right-sided. Next, please. Diagnosis, most of these are performed by biopsy, and Ki-67 is obviously a very important marker to determine aggressivity of the tumor. This can be done either percutaneously with ultrasound guidance, and ultrasound is a very elegant way to get down into the tumor and make sure that we're not traversing any big vessels on the way. Also, this has been advanced endoscopically, so EUS can be performed, and biopsy. You can see that's the needle right there with the arrows. The needle is the white line, and the tumor is the dark area inside of that hazy black and white appearing picture. Next, please. Image-guided biopsy with CT guidance. We can be very sophisticated. We actually have electromagnetic guidance, and it's like playing a video game that allows us to advance the needle virtually into the patient without ever even piercing the skin. So we can check the angles, we can know the depth before we even get started. It's something that helps improve accuracy and decrease complications. It's not available everywhere, but there's a specific device called VERAN, V-E-R-A-N, that we use and have been using for about 10 years, and I think it's very, very accurate. How many biopsies do we take? Well, typically you have an outer needle that gets you down there safely, and then you can take repeated core biopsies. We tend to use an 18-gauge needle, which is kind of a medium-sized needle, and we're trying to get as much tissue as possible so that we can do the stains that Dr. Liu is requesting. Again, Ki-67 is one of the main things that we're looking at. Next, please. Different devices. Usually it's a hollow type needle system that you deploy and can pull out the pieces of tissue. The nice thing about having an outer needle and an inner needle is that we can continue to take pieces until the pathologist says, yes, you have an adequate sample. Image-guided biopsy, it's not without complications, but it is very safe. Complications are about 1%. Complications include bleeding, and there are ways to decrease the risk of bleeding at the time of the procedure. We can inject gel foam, which is a medicine that helps promote clotting. There's also if there is bleeding that's encountered, especially in the liver, we can do an angiogram and stop that bleeding from the inside. So it's rare to ever have a real surgery to stop the bleeding. There's also a risk of tract seeding, which is far less than 1%, and that just means anytime you put a needle into a tumor and you pull it back out of the skin, there's a risk that some of those small tumorlets could follow the needle on the way out. So then we talk about localized versus regional liver therapy. The ultimate localized therapy is surgery. So with Dr. Liu being in town, there's many more people that can undergo surgery than there were previously. If there's a more starry sky appearance or disease that's spread throughout both sides of the liver, that's better treated regionally, meaning through the artery or PRT or some of these other therapies that are available, as well as chemotherapy. So the gold standard, what everybody's held to really is surgery. There were some older therapies where we could put needles in the individual tumors. If there were 2 or 3 tumors, we could inject alcohol or acetic acid, and it would help burn it up from the inside. Then there's thermal energy, which requires you actually placing a needle. You can heat it up with microwave or radiofrequency ablation. You could freeze it with cryoablation, and there's benefits to either of those. Dr. Liu talked to you about nanoknife, which is an energy being passed through there that doesn't damage adjacent tissue. And there's also external beam radiation therapy for localized tumors. The barriers to liver resection, this probably doesn't hold up as much for patients with neuroendocrine disease, but in general, people who have metastatic disease to the liver, only 10 to 15% of patients are actually candidates for a surgical removal. Now, with neuroendocrine, the goal isn't always to eradicate the entire disease, it's to debulk the disease. And Eric, do you have a feeling of what percentage of patients actually can have a surgery? That's a true surgeon. And that's part of the multidisciplinary discussion is who's going to benefit from a surgery versus an ablation versus a regional therapy. Radiofrequency ablation, the top picture is just an ultrasound-guided needle being placed. It's just a single needle. The bottom is a tined-based device that has multiple little probes that come out. Most of these are good for tumors that are about 3 centimeters or less in size. But again, if it's in a good surgical location at the liver capsule, those are great patients to have a surgery and have them removed. That's what it looks like when I do it. When Dr. Liu does it, there's a much bigger incision. And this is a patient with a tumor on the backside of the right liver lobe. The red circle is showing the tines being deployed. As we heat things up, we create microbubbles inside of the liver, and it's very hard to see through things with ultrasound. Once you encounter bubbles, they reflect back and appear white, but you can't see further away. So it's always important to treat further away and then work back towards yourself. This is what it looks like when you can see the baseline scan. There's a tumor in the backside of the right lobe, and those 3 dark dots are necrotic areas within the tumor. The patient was treated. The tumor starts to become more dark. So this area of the liver is never going to look normal. But if you were to do an Octria scan, a PET scan, or contrast-enhanced studies, they would not enhance. That's the goal. And then there's capsular retraction over time. Usually at a year, we start to see things shrink down a little bit. It's still always going to be abnormal. The white blood cells come in and eat that area up and replace it with fibrotic tissue, so it's going to be a scar. This is a study, and it wasn't really with carcinoid, but the reason that I show it is these were patients that underwent ablation prior to chemotherapy, and then there were patients that had chemotherapy that were treated with ablation. Patients did much better if they had ablation first, probably because of the debulking effect. There's probably some selection bias too, because not everybody can undergo an ablative technique. We've also, microwave has come on the scene in the last 5, 6, 7 years, and the nice thing about microwave is we can create much bigger zones of tissue death. 6 centimeters by 5 centimeters with a single needle. We could do that percutaneously. You have to be careful of all the adjacent structures because when you burn something, it doesn't discriminate between tumor and everything else. It'll burn through small arteries, it'll burn through bile ducts, so you have to know exactly where you're working. Cryoablation, same thing, we insert a probe, but we freeze it instead of heat it up. We freeze it to minus 40 degrees centigrade. Actually, we freeze it to minus 300 degrees centigrade, but to get tissue depth, you need to be at between minus 20 and minus 40. It does preserve collagenous structures, so if we're working in the liver, it will potentially preserve the bile ducts and the vessels. This is a patient with a tumor on the back side of the left lobe of the liver. You can see with the blue arrow there. That would be very dangerous to put a needle in and just do a percutaneous procedure. Can you advance that, please? Thanks. But that is an area that Dr. Liu can get to and move it out of the way, pull it away from the stomach, and do a surgery. In this patient, we elected to put a cryoablation needle in, and the stomach is being pushed a little bit posteriorly. If we were to burn this area, we'd create injury to the stomach. If we're going to freeze this area, the stomach actually survives and does very well. Advance, please. And that's what the ice ball looks like. It actually creates an ice ball around the needle. This is a nanoknife. Dr. Liu spoke of this, but you have to place these needles very precisely. We can do it percutaneously, probably a better surgical procedure because you have to be very, very precise in where you're putting these needles. The liver actually looks like a bomb went off in it within the first month, and then at 3 months, next please, things start to resolve. So this is from Dr. Nanierian down at University of Miami, a PET scan demonstrating a tumor within the anterior aspect of the right lobe, treated with nanoknife and resolved at 6-week follow-up. Most patients are going to get some kind of 3-month follow-up. So with radiofrequency ablation or microwave, you can do it as early as 1 month, but there's a lot of edema that happens around these things. There's a fair amount of injury, even though it's just replacing 1 or 2 needles. So we tend to wait 3 months to get follow-up scans. They can be MR scans, they can be Artery scans, or CT scans. I would say that most people probably get CT scans just because it's more common in the community. Stereotactic radiosurgery or nanoknife. This is external beam radiation therapy, and this has advanced significantly over the years. They weren't able to target very well. Now there's multiple beams of radiation coming in with a robot swinging it around. It's very good local control for smaller tumors, 1 or 2 tumors, and very reasonable to consider for liver therapy. Regional liver therapy. Once you start getting more than 3 tumors that are about 3 centimeters in size, then we start talking about regional therapy, which is being delivered through the artery. The picture on your left shows that there's 3 hypervascular tumors. So the nice thing about neuroendocrine tumors is that they are very vascular. So whenever we inject something in there, the dye is showing up dark here, there's more dye in the tumor than the normal liver tissue. We take advantage of that. So whenever we deliver a therapy in the artery, it's going to hyper accumulate in the tumor and spare the normal liver tissue. You can inject bland particles, you can inject chemotherapy agents, as well as radioactive materials. And there's even one paper where they did chemotherapy and radioactive materials together, but I wouldn't recommend that. What are we trying to do? Cytoreduce. We're trying to get rid of symptoms. So even like surgery, we're not getting rid of 100% of the tumors. We've treated patients that have either then gone on to liver transplantation or resection, and we've seen that these tumors die. They don't die completely. Some tumors have 100% response. There's many tumors that have a 90, 95% response. So all you need is a couple of tumors to survive, and then it will grow over time. But similar to a surgery that's not going to be an R0 resection getting rid of everything, this is a great way to reduce the burden, which in turn can reduce the symptoms. Hepatic artery therapy, we know that in general, tumors, a colorectal cancer in the liver, there's 3 times more arteries that go to the tumor than the normal liver tissue. So it's going to steal these beads, or whatever we give, into the tumor. The liver is supplied by a portal vein and hepatic artery. We've known for years that we can block off the hepatic artery entirely and the liver still survives. We also know that the liver gets up to 100, or the tumors get up to 100% of their blood supply from the artery. So we don't treat these things from the portal vein. We actually treat them from the artery where they're getting the oxygenated blood supply with the nutrients. Will that play? Really? Okay. We don't have to play it. It's just showing a catheter that's being delivered through the artery. The catheters now are very, very trackable. 10 years ago, it was somewhat difficult to do, but now we have catheters that can get out into the tumors. If there's 1 or 2 tumors, we'll go into those 1 or 2 tumors and treat them, trying to spare as much normal liver as possible. Most of the patients that I see, though, have tumors spread throughout both sides of the liver, requiring probably a whole liver treatment. And that may be divided in 2 separate sessions, or it may be given in 1 session, depending on how well the patient's doing on a day-to-day basis. Next, please. There's 8 segments in the liver, and sometimes we'll use this to figure out exactly which artery to go in. If there were segment 7 or 8 tumor, that's the arteries we would go in to treat it. Who are the candidates for regional liver therapy? This was put out by Dr. Kennedy, and it was specific for neuroendocrine disease. And patients need to be relatively healthy. They need to have liver-dominant disease. As Dr. Liu was saying, we want to treat the leading edge of the disease. So if somebody had much disease outside of the liver, it's probably better to consider other therapies first, stabilize the disease. If the liver were to progress, then we start talking about liver-directed therapy. Bland embolization really is just a particle. It's a little tiny particle, polyvinyl alcohol that's injected in the artery. The red blood vessels are 7 microns in size. These particles are about 40 to 100 microns in size, so they're very small. They travel downstream and create ischemia. And a lot of the original papers were done with just bland embolization. Then they thought, if we can mix chemotherapy along with bland embolization, it will block off the blood supply. It will give the chemotherapy a longer time to dwell in the area of the tumor because it's not just rushing away, which the thought was that would help improve outcomes. There's different chemotherapeutic agents that people are using. The results of hepatic arterial embolization and TACE. So HAE is just a bland particle. TACE is a chemotherapy mixed together with the particles. And the survival was anywhere from 80 months to about 30 months, looking at a meta-analysis of papers. Fairly well tolerated, although it does usually require a hospitalization. The goal of a bland embolization is to pack as much stuff in there as possible to shut the blood supply down. And whenever you create ischemia, that tends to create pain. This is a study out of MD Anderson looking at 81 patients back in 2003. And 75% of them showed a response to therapy. Stable disease is a response as well. And about 9 to 10% of patients actually progressed. So it's a good therapy, and it has been for a long period of time. I think that the catheters that we use now, some of the other agents will help improve these numbers. TACE results, this was a 15-year retrospective analysis where they looked at 123 patients. And you can see the overall survivals listed there. They had 14% of patients who had progressive disease despite their therapy. So most of the therapy that we use now, I would say we get somewhere between 90 and 95% of patients respond. We only see about 5% of patients who actually have progressive disease. There's something new on the market. It's not that new anymore. It's probably 5 or 6 years old, called drug-eluting beads. They're actually beads that you soak in chemotherapy. The chemotherapy goes into the bead like a sponge and gets locked inside of there. We can use doxorubicin and irinotecan. We inject those beads. They travel down into the liver. They get stuck, preferentially in the tumor, and then they slowly elute that chemotherapy over the next 2 weeks. So there's very low systemic toxicity. You don't get that sick, but there's prolonged exposure in the area of the tumor. There's some controversy right now as to, is this the right thing to do? And we'll talk about that. Next, please. This is looking at drug-eluting beads, so that specific product. There's 3 manufacturers right now that create it, and it looks like it may cause more damage to the biliary tree. So we want to make sure that everything we do is a risk-benefit ratio. We want to make sure that we have the best chance of helping you with the least chance of hurting you. So drug-eluting beads are used around the country, and they're pretty easy to use. So I would say they're replacing a lot of the TACE. So I think it's important. If I were a patient, I'd ask the doctor, what are you planning on using and why? And what size particles? I mean, those are, and I think you'd probably get some different answers because there is no standardized delivery, but those are things that you should know. What happens when you get treated with drug-eluting beads? And I would say this is fairly similar for chemoembolization as well. So just the chemo and the beads together versus these special beads. Most people get some amount of nausea. You can have low vomiting. We pre-treat for all those things, but we do keep you at least 23-hour observation. Whereas with the radioembolization, I let people go home in 2 hours. So we know that this creates some ischemia. It can cause some nausea and vomiting, and fatigue. The fatigue starts a couple weeks after the actual procedure. But patients do very well with this. Who gets what? Who gets TACE, which is the chemoembo, versus just the bland beads? Well, there's only one study that really shows a trend towards improved survival, and that's in pancreatic neuroendocrine disease. So although we do lots of chemoembolization, there's not great data to support it. Patients probably do as well with just bland embolization beads. And there is an increased toxicity with the chemotherapy. So if we're talking about lung disease, I would favor either radioembolization or just bland embolization with particles. TARE, this is known by lots of different names. Radioembolization, yttrium-90, TheraSphere, Sursphere. There's 2 products that are commercially available. Thousands of patients have been treated. It's an off-label indication for this product. Radioembolization really is only approved for hepatocellular carcinoma, which is a tumor that actually starts in the liver, or metastatic colorectal cancer. So everything else is off-label. The nice thing is, in most of these policies, they have included neuroendocrine disease. So 15 years ago, it was very hard to get insurance authorization. Now it's pretty easy, but you do need to have some symptoms, so that the insurance companies want to see some symptoms. So if I'm pressing patients for abdominal pain or flushing or diarrhea or other things, it's because I want to put it in a dictation so that the insurance company has to say, yes, you can treat this patient. The interesting thing about radioembolization is the liver can only tolerate 30 gray and it starts to die. So the arteries, vessels start to occlude at 30 gray. The tumor has to get between 70 and 90 gray to die. So how do you get this preferential uptake in the tumor and not the normal liver tissue? Well, that's what we see with, next please. That's what we see with this increased vascularity or blood supply to the tumor. There's resin spheres and there are glass spheres. There's a whole debate in our society which is better and when to use which. I think that they both work well. I tend to use the resin spheres because it gives me a little bit more flexibility when I treat the patients. Next, please. This is an electron micrograph of the radioactive microspheres. They're a resin-based sphere. They contain yttrium-90, which shoots off a little photon at about 940 keV. If you get a chest x-ray, that's 70 keV. So this is very, very high energy. It only travels about 11 millimeters around each bead, and we inject about 30 million spheres. So each bead is a point source of radiation, and when you get 1 million beads in an area of tumor, it creates a cloud of radiation. And that's how it helps to kill it from the inside. We do angiography. We need to look, next, we need to look at all these little branches. This is a stomach branch, and if you didn't block off that branch with the little coil that we see here, the patient could get an ulcer, and that can happen in 5% of patients. I would say it's directly related to the experience of the operator. So personally, I think a family member, I wouldn't have them do the first 20 cases with somebody who's just getting this therapy unless they've done lots of chemoembolization. And I say that from experience. I've done about 1,300 of them, and I think the first 100 that I did, I didn't really know what I didn't know. As you get better, you understand where these vessels are. The technology has improved. Now we have cone beam CT, which will create a CAT scan as we're doing the injection, which helps modify and make it a much more specific procedure. You have to have a mapping procedure. This is just showing the radioactive beads going in the liver with a very low dose to the lungs. This is the actual, the beads. They look like little sand particles. There's an inflow needle and an outflow needle. We puff them into suspension, and they're delivered into the tumor. This is done with conscious sedation, so we give you fentanyl and Versed to get you sleepy and comfortable. It tends to take about 1 hour. Patients are discharged about 2 hours after that. We're starting to do them from the wrist now, the radial axis, and I'll show you a picture of that. TARE results. They're fairly similar to TACE results and bland embolization results. We were participating in a trial back in 2008, and the median survival was about 70 months, 5 years after the treatment of the radioactive beads. Some of these other papers have a little bit lower survival. I always hate talking about survival because it's very independent. If you have somebody who has a median survival of 70 months, well, there are some people that do great for 10, 15, 20 years. And I think it all depends where you catch people in their disease. Next, please. This is something that was published out of Northwestern, and it just shows that greater than 90% of patients responded to the radioembolic therapy. Next, please. This is a paper that we published looking at 148 patients. Most were patients with carcinoid disease. Some people underwent 1 treatment, others 2, someone underwent 3. Most of the time in my practice, if somebody has a good performance status, meaning they do well on a day-to-day basis, I'll do the mapping angiogram. If the bilirubin is normal, I'll consider treating the whole liver at one time. That saves you coming back for an extra treatment, left lobe, right lobe. It also allows you to get back on therapy quicker if you need to be on some other therapy. Next, please. These were the subtypes of tumors. Next. There were only 5% of patients who developed progressive disease. It's not uncommon to see these types of symptoms. Most people feel good for about 3 days, and then you start feeling tired. And the tiredness lasts about a week to 2 weeks. We give you a steroid dose pack that helps boost the energy a little bit, but that's not why we give it. We give it to decrease the swelling of the liver, which can create capsular stretch and pain. So people who are flying in to get treated, we do lots of that. Patients will fly in on a Monday, we'll do the mapping on a Tuesday, treatment Thursday, fly home Friday. And then you kind of feel crappy when you get home on the Monday. But patients actually tolerate it very well. Next. This is just 5% progress. Next. It's important for you to know and your physicians to know that the chromogranin A or tumor markers in general will go up after treatment. They will spike it at 2 to 4 weeks, so they'll be higher than when we started. And when we initially started using this therapy, we would do CAT scans at 1 month. Well, all CAT scans look worse because there's edema or swelling that occurs as the tumor dies. The tumor markers are getting worse. So usually if you see a tumor marker getting worse and a CAT scan getting worse, that's progression of disease. But what we found out is you just have to wait it out. And that's why we wait for the 3 months, is because the edema, the swelling resolves, the tumor markers start coming back to baseline or lower in that 2 to 3 month time frame. So you get a much more accurate evaluation of the response to therapy at 3 months. In our study, we just showed that the tumor markers very closely correlated with CAT scans. How do these tumors die? Well, this is a patient who had a tumor in the backside of the right lobe. This is not a neuroendocrine tumor. Was treated 3 months later. Now that tumor is very dark. You can see the right-sided slide is after the treatment. So usually when we're looking at tumors, we want to see if there's vascularity. If there's an arterial blood supply, it tends to be alive. If there's not, then it tends to be dead. And that's some of the new criteria that they're looking at to tell how response to therapy, because it's still very crude how we look at things and say, did you respond or not? Next, please. So this is the actual liver. That was the tumor in the backside of the right lobe. Next, please. This is the tumor, and you can see these boxes here. That's where the radioactive beads are accumulating. So all those little black dots, those are the tumors. Tumors tend to have more vascularity at the periphery of the tumor. That's where the angiogenesis is happening. Many times in the center of the tumor, it's actually more dead or necrotic. Next, please. These are the beads, those little tiny dots, and then the pink tissue is actually all dead tissue. That's coagulative necrosis or cell death that occurs, that the white blood cells come in and replace. We said that you had to be at about 70 gray to kill a tumor. This is showing that particular tumor with much of the tumor covered by at least 100 gray and several areas with 1,000 to 3,000 gray. So it's just It's overkilling some of these tumors. There's still lots of dosimetry work to be done, but I think it's a very safe procedure with a good therapeutic index. A low chance of hurting you with a high chance of helping you. Next. When we look at Y90 radioembolization after chemoembolization, so my preference, and this is just my preference, is that we should probably radioembolize first. The reason that I say that is when we radioembolize with Cersphere or TheraSphere, we don't block off any of those arteries. I've gone back in patients and retreated. Whereas with chemoembolization, the endpoint is stasis. You're trying to stop the blood flow in there. And I have had patients that have come to me after chemoembolization who wanted a radioembolization, and those arteries are now gone. So it makes it very hard to sequence radioembolization after chemoembolization. Not impossible, but definitely harder in some patients. And the results just aren't as good. And that's probably a selection bias. It's people that have had a lot of stuff done to the liver before we give them the radioactive beads. Common toxicities, again, most people just have a low-grade nausea, fatigue. It's rare to get an ulcer. If you do get an ulcer, it's usually because there's an artery that wasn't embolized or excluded from the treatment zone. It's less than 5%. Less than 2% of patients can develop a cholecystitis requiring surgery. Many people have already had their gallbladder out because of the sandostatin that's going to be administered. Yeah, and another thing that you should hear about is RILD, or REILD, radiation-induced liver disease. And it is a problem that can occur in less than 1% of patients. It's a veno-occlusive disease that can be fatal. So some of the veins can block off, the liver gets swollen, you can develop ascites, the bilirubin goes up. We have been able to treat patients with steroids and non-steroidals that can help. And I would say if you have ascites, don't freak out. This is very, very uncommon. I think we create some inflammation in the liver whenever we do something that can create a little bit of fluid. That resorbs over time. What I'm talking about is somebody whose belly continues to get bigger over time, and usually the time frame is about 3 to 6 months, so it's not a week or two, it's further out than that. This is what a ulcer looks like, that little white thing, and that's from inadvertent embolization. This is from MD Anderson. This is not my case. Next, please. This is the REILD, radiation-induced liver disease. Bruno Sangro from Spain published this paper early on. Who are the people that are more likely to get RILD? Well, low tumor burden. That makes sense because you're not stealing the beads away from the normal liver, so the normal liver is getting a relatively high dose. Whole liver treatments because you're treating the whole liver at once, and people who have seen a lot of therapy in the past. This tends to be more breast cancer patients, maybe colon cancer patients, not so much neuroendocrine disease. Cautions, you need to make sure that the veins that are draining the liver are open. You need to see where the bilirubin is living. That's a pretty good predictor of what the hepatic reserve is. We treat patients with a bilirubin less than 1.5. If it's on the rise, 1.5 1 week, 2 the next week, 2.5 the next week, then I think we have to be very careful in those patients because what it's showing is the liver is starting to feel the effects of either the tumor or something's pushing on a bile duct. If it's pushing on a bile duct, those things can be fixable by putting in stents, getting the bilirubin down to a more normal level, and then treating the liver. Ascites ascites is fluid outside of the liver. That means that you're starting to feel the effects of the therapy. And people who have a violated ampulla, those tend to be patients that have had Whipple procedures. That's more a pancreatic neuroendocrine issue. But anytime you have a stent in your biliary tree, it puts you at risk of developing an infection inside of the liver. I'm trying to kill tissue, tumor tissue, but that can then become seeded with bacteria from the gut. So we prevent that by giving people antibiotics during the procedure. If you have a TACE or a TARE, a TACE or just a bland embolization, the infection rates were up to 50 to 100%. If you used radioembolization, we just looked at some retrospective data, the risk of developing an infection is 10%. So much, much lower. Not completely safe, but safer in patients that have had biliary instrumentation. The benefits are it's repeatable, it's well tolerated, it's an outpatient therapy, people go home the same day. These are some consensus guidelines looking at radioembolization versus the chemoembolization or the bland and saying they're probably about equivalent therapies. Next. It's also important for you to talk to your team about what you're getting, because looking at this paper in 2012, it was the discretion of the interventional radiologist what you got. So you get sent to your interventional radiologist for embolization of your liver tumors. That's probably institution specific. If you came to me, I'd probably radioembolize, but if you went to somebody else, there's a good chance you may get bland or chemoembolized. I think it's important to see where you fit in this algorithm, because you're your best advocate, you and your team, for playing the cards in the appropriate order. Next. Next. So the question comes up, PRRT and radioembolization. And this is a study out of Germany, looking at patients who had received PRRT and then received Y90 therapy. The reason that that's important is that the liver remembers, your body remembers how much radiation it's seen in a lifetime. And 1% or greater is accumulated within the liver itself. So we need to know how much dose can the liver tolerate before it fails. In Germany, these patients were treated with PRT and then radioembolization, and they did well. So no increased adverse events from this combined therapy. This was a European population, which is a little bit different than the US. Next, please. So this is US data, which is a meta-analysis, a bunch of people pulling data together. And what it shows is they got treated with chemoembolization, and they got treated with PRRT and Y90. So in the US, PRRT is not as available as it is in Europe. So patients who have liver tumors, it tends to get more beat up over time because we can chemoembolize, we can radioembolize. And then if you get PRRT on top of these other therapies that have been done over years, there's definitely increased toxicity. So the thought is, in the United States, people who undergo PRRT as more of a last-ditch type thing, there is increased adverse events that we see. And that will change. The goal is trying to figure out who's going to do well with which therapy. Can you go back one, please? So I think you also need to talk to your interventional radiologist about what are you going to do if I have a carcinoid reaction on the table. I mean, I've had patients come to me who went to other doctors and they said, well, I'm not sure I would consult internal medicine. Most of the time we're going to give you 100 mics to 200 mics of octreotide before we do the procedure, sandostatin, just to help block any reaction, because we're in the liver, we're going to stimulate these tumors. And patients who are very labile will start an IV drip at 100 micrograms an hour, and we can dial that up or down based on symptoms. I probably treated 150 patients with neuroendocrine disease. We only had one patient that needed to be admitted to the ICU, and he was discharged the next day. Short and long-term effects of these therapies. Post-embolization syndrome is pretty common in TARE, in just a bland embolization or chemoembolization, and that's low-grade fever, pain, feeling not so great for the first week. You can have biomas that occur with the drug-eluting beads. Radioembolization, it does require one additional angiogram, and you have to know that going into it, because we need to do the mapping and block off any branches that go outside of the liver. But if you have a good performance status, it can treat the whole liver at one time. So it is a mapping and then a treatment, so it's two separate angiograms. And then long-term radioembo versus chemoembo, there is scarring that can occur with the chemoembo that may not allow us to radioembolize later on. And I would say most of these are repeatable. So that's where we are as far as what can we put in the liver and how does it respond. There are some newer delivery techniques. What we used to do is put a little tiny garden hose in, go up into the tumor and dribble in these beads. Well, the tumors would only take up so much and then they would stop. And so if they stopped after 10% of your therapy, you were stuck. That's all you could give. Can you advance one? So if we look at this top picture, so this is an end hole catheter, which just means that it's a garden hose in the right side of the liver. They're dribbling in these beads. The tumor in this patient is right here at the top of the right lobe. You can see the tumor is actually up here. There's a fair amount of the tumor that is not being perfused or taking up the therapy. Whereas now we actually have a catheter that flutes out and allows me to push things further into the tumor with decreased risk of it going backwards, to the point where I can actually give 67% more dose in this particular patient with decreased risk of it going elsewhere. And there's some data out of Georgetown looking at chemoembolization, and the results are pretty phenomenal. So I think that the delivery systems are starting to catch up with the radioembolization in some of these therapies. Does that play on the left? Okay. So we're starting to do more and more from the wrist. The patients like it. It's a little bit harder for me because instead of working from the groin to the liver, which is this long, or working from the arm to the liver, which is this long, they've created catheters that make it easier to do. We had a patient a couple of weeks ago that we treated him on a Friday, and he ran the Boulder 10K on Monday. So it is, people like it. You know, if you're not in the groin, if you can do it from the wrist, it's just another way to deliver the therapy. Next, please. So in conclusion, I think cytoreductive therapies, surgery really is the mainstay. We can do some of the ablative techniques with image guidance as well as catheter-directed therapies. PRRT, I think we need a little bit more data as we're moving forward. We obviously don't want to treat people and put them into liver failure. Dr. Woltering is fairly adamant against Y90, radioembolization, and PRRT. They've had some bad experiences down there. We're trying to figure out if that's dose related. I just don't know. I've done it several times, and patients have done fine. But I think that the great thing about being here is you all can tailor your individual therapy with your team and have them talk amongst each other and make sure you play your cards in the correct fashion. Thank you very much.